My name is Eric Eyre, and I was asked by the folks that are filming today if I would make my opening remarks up here. And I don't have a ton because I think we have a number of experts that are going to speak today. But again, I think this does kind of reflect what we're hoping that this group has become, which is that place in our community where we can have discussions around behavioral health and public safety and what our needs are around enforcement, what our needs are around treatment, what our needs are around housing. And this continues in that tradition. About a year and a half ago, maybe 2 years now, I had the opportunity to sit on a statewide committee to look at what we wanted for around justice reinvestment, but behavioral health. So JRI was traditionally used for nonviolent drug and property offenders to look at alternatives to prison and what we could do with the savings by utilizing community resources rather than state resources in prison to work with folks who are dealing with addiction and when that addiction is fueling their criminality. So the thought was, what could we do to look at behavioral health in a similar way? And a group came together, 3 or 4 different meetings. It was all different sectors of the state were represented, from consumers of services, advocates for different justice outcomes, public safety officials, community corrections was there. And at the center of it was Steve Allen, who at the time was with the Council of State Governments. And Steve did a masterful job of making sure every voice was heard, making sure we still move toward a work product. And currently, when we see the impacts grant process, that's the byproduct of that group that Steve headed and got these results from. I was hopeful that Steve would be able to come and speak a little about how that process worked, because just on a strictly, and not to nerd out on this, data level, we were able to look at Oregon Health Authority data, Oregon jail admission data. We were looking at people's status as to whether they were housed. We were looking at all these different systems together, and it just kind of gave hope and shine and kind of put a light on the idea that the data is out there, and it does take a concerted effort. It takes a lot of pull at the state level, but what can we do when we get some of those numbers, and what do those outcomes look like? But today, our first speaker, want to hand the floor over, and Steve, thank you for joining us.
You want me to speak from here because you're recording?
If possible.
Absolutely. So thank you so much, Eric, and thank you for your time on the steering committee for what became the Impacts program. Your help in insights were really helpful along the way, as were the other members. A number of things happened in the course of this project that were unique, and as Eric mentioned, at the time I was working for the Council of State Government's Justice Center, where I'd worked for 4 years, worked in 10 states, and my role was to look under the hood in states and see what they had, see what they needed, make recommendations for improving behavioral health services, especially for complex criminal justice involved individuals. As we came to Oregon, there was a number of unique factors, and what had happened just prior to this Oregon project was our funders, the Bureau of Justice Assistance, convened a 50-state forum, and the idea was that justice reinvestment projects through BJA, through Pew Charitable Trust, have been going on for some time. Oregon had benefited from that work. What was the next iteration of justice reinvestment type projects that the states were really interested in? And so they had an opportunity to raise their hand and say, here's this new project idea that we have, would you consider funding it? And Oregon's project was the first of its kind that looked in 2 ways. One is all projects prior to that had been state-based, and what I mean by that was very similar to the prior Oregon Justice Reinvestment, where the idea was either to not build a new prison or to even stop using a prison and use that savings from a prison-based approach to criminal justice to infuse it with community resources to impact public safety over the long haul. The new approach here was to, instead of looking primarily at the state level, and as you'll note, there are some state implications for this, look at the local level. So begin this project looking at local communities, and rather than prison, look at jail and community corrections and emergency department, local acute care hospital utilization as a place to start. So engagement with local communities, and that was important because in many cases in prior justice reinvestment projects, and I'm not speaking about the Oregon project because we weren't involved in that project when I worked for CSG, but many times local communities felt like the state was solving its problems in corrections on the local government's back. In this case, the whole project started with a local initiative, which we thought was really cool, and BJA supported that. The second unique factor was a focus on behavioral health. And as you might guess, increasingly over the years, behavioral health became a focus of all of these justice reinvestment projects, so that's why we're busy in this space. But to have it be the focus of a project was the first of its kind. So the Oregon project that led to the Senate Bill 973 and the impacts program was unique on those levels. Another unique aspect was the way that the data was collected, and Eric has alluded to combining multiple sets of data that we had never been a part of, and Bureau of Justice assistants had never been a part of a data analysis that was so robust. And that's the piece that Eric and Stacy wanted me to bring forward today, but happy to talk about the other aspects of this project. Part of the reason this is important right now is because the impacts program, and Stacy sits on the committee for that, the grants committee, it's rolling down the pike, and those fundings, the $10 million that was set aside for local community pilot project, will be going out the door later this year, hopefully by late spring, late summer at the latest. So you here will have an opportunity to write a request for that, and it may be helpful for you to zero in on the population for which this project was intended. Having sat in on the meetings this morning, it also seems like this hits right square where some of the challenges that you're currently struggling with in terms of aid and assist and guilty except for insanity population, sort of that this project fits really nicely with some of the challenges that you're presently working on. So with that, unless there's questions, I'll jump into this data, and then depending on your interest and time, would be happy to address other pieces along the way. Any questions before I move along? And I should say, because I'm going to probably use the words we, because I was, as Eric mentioned, deeply involved in this project here in Oregon, kind of putting on my old CSG hat, but I'm the current behavioral health director for the Oregon Health Authority. That's the role in which I'm presenting this information. I just may slip now and then. So as Eric mentioned, I'm going to step ahead because some of these it's easier to point to. The goal here was part of the data. We wanted to better understand what was going on at the local level. And the idea, because if you think about this, we weren't looking at freeing up the costs of either building or utilizing prison-based resources as often. So you sort of in a justice reinvestment, you think, well, you're going to move money that you would have spent here and you're going to move over here. So we needed a way to begin to have a data process that would articulate or zero in on where are the potential cost savings. Now, what we didn't have available to us, for instance, is the local law enforcement, the court costs, other parts of the system. What we did have available to us is information about community corrections, risk assessment, and the healthcare costs. We thought at least that's a beginning to show patterns of utilization of this population and the opportunity to change those patterns and to look at improved costs. So for centers of data, we requested jail data from all across the state and had some challenges. In some cases, jails weren't interested in providing this data, although most jails were. In some cases, as you know, if you're familiar with the jail data here in Oregon, I think there's about 6 different data systems that are used by various jails, and they don't talk to each other very well, depending on which system that you use. So some of the data that we had available to us, simply we couldn't combine and use with other data, so there were some technical aspects to it. In some cases, the data wasn't available soon enough to be used for this project because there was a clock ticking on getting it. But in the end, we were able to get 9 jails worth of data that represents 12 counties, and that represented about 65% of the overall state population, so a wide swath. And it included both metro, rural, and frontier county data, so we had a nice spectrum of types of counties as well. So that was the foundation. All of the other data was then connected with the individuals who went through those 9 jails. And for the year 2017 is the data that we reported on at CSG. We then had the opportunity to combine it with community corrections data, and why that was so interesting, and you'll see some data that around that, is to be able to obtain what is the connection between a population going in and out of Oregon jails. So what's the overlap with community corrections? You'll see that data. And then, most interesting, what is the risk data look like for, because Oregon uses a standardized approach to doing recidivism risk assessment, and we were able to combine it with that data. The Medicaid data, which gets to the healthcare utilization, you'll see data on that, and then state hospital, and that is the anchor in the state area around the hospital utilization, and as you know, that's been really a critical issue for the last several years, but very acute right now. So what we ended up with, driving towards, is a population of people who had frequent contact with Oregon criminal justice system and healthcare system, and you'll see the words frequent criminal justice involvement. That was the label that we put on a subgroup of those individuals who had 4 or more jail bookings in the year 2017. Why 4? Did a statistical analysis, and the outcomes for people who had 4 or more were different from those who had 3 or less. So that was the cutoff point. Some of those individuals for the year that we had, and the jail data we had up to 19 jail bookings. So there was quite a range in this process, as I'm sure is not surprising to you. I'll come at this data in a couple different ways, and please feel free to jump in with questions. So the first thing we looked at is, here's this frequent criminal justice involvement. And again, every time I use that word, I think 4 or more jail bookings, and everybody else is 3 or less. So if we looked at the individuals, these aren't jail bookings, there was about 100,000 jail bookings, but if we looked at the individuals, about 9% are these 4 or more, and then the other, the rest, the 91% were the non-frequent criminal justice. In terms of booking events, this is kind of what you'd expect, right? These people have 4 or more jail bookings. Of all the jail bookings now, that's about 30%, and these are the rest. And then bed days. So this frequent criminal justice had 9% of individuals booked in, representing almost 30% of the jail bookings, but only 16% of the bed days. Why is that? Well, if you think about it, it kind of makes sense, because to have 4 or more jail bookings, you're in and out of the jail, right? So in some cases, people are booked for a year or more in a jail, and that's going to add a lot of bed days to their history, but they're not going to be in that frequent criminal justice involvement. So it kind of works out that way. Now, this is coming down to the summary of what you're going to see next, but I wanted to give you that first so you have some context to it. So the idea is to capture this group of people with 4 or more jail bookings, and then to look at those individuals who had a serious level of behavioral health conditions. That means either a mental illness, a substance use disorder, and in many cases both. So it's this shared population where we think there's an opportunity to intervene differently to change the trajectory of all these jail bookings and other healthcare utilization. So again, looking at those with 4 or more jail bookings, that's a focus population. Almost 80% had some history of community supervision, probably not a surprise. 2/3 were considered high-risk, high needs, and remember from the risk needs analysis, we're not talking about dangerousness here, and you'll see a slide that goes towards person-involved crimes and non-person-involved crimes. This is the risk of recidivism, staying involved in the criminal justice system if you've already been involved. That's what one of the elements that those risk assessments do. So high-risk, high needs. 2/3 were OHP members. As you'll see, we think that number probably ought to be higher, but remembering some of these individuals are coming out of jail where their Oregon Health Plan benefits were either terminated or suspended. We think that it's likely that there's a lot more of these, maybe in the area of 80–90% who are OHP members or could be or would be eligible. They're much more likely than the either the Oregon population as a whole or people with 3 or less jail bookings, no surprise to you, much more likely to have a mental illness, substance use disorder, or both. Much more likely to visit emergency departments. Again, no surprise to you, but it's nice to have the data to support what we see, and they're much more likely to be homeless.
So can I just ask a question real quick?
Yep.
Going back to your first slide, basically 9% on average of people booked into jail are these people that are more likely to have a mental illness, an A&D issue, or be without housing?
Yes.
Okay, so only 9%.
Did you all do the data on the other?
Yes. You'll see that.
80, okay.
It's not either or, right? So the group who come into jail even once are much more likely to have a substance use disorder, mental illness, and then there's another step up for this 4 or more. All right, so this is the first slice of this information, and where we start out with is there's about 500,000, and this is adults, if you're familiar with the Oregon Health Plan. If you add children, this number doubles. But there's about 500,000 people in 2017 who are on the Oregon Health Plan. And we look at, if we just ignore these for a minute, what's their likelihood, and this is based on the encounter data. So if you're involved on OHP and you go to the doctor or you go to see services, there's a billing for that services, it's coded, it gets entered into a database, and then it's available. So this is for all of these 500,000 people in the Oregon Health Plan, and in 2017, about 17% of them received services for a mental illness, not a surprise. 6% received services for a substance use disorder, and then about 3% received services for both. So now if we jump to the people who, in this case, this is all booked people. So this is the 3 or less and the 4 or more. We had to do cuts differently based on the data that we had available. So some of this you'll see sort of cleanly as the frequent and the non-frequent. Here is all booked person. What you'll see is a nice substantial jump from 17 to 27%, from 6 to 38% on substance use disorder, and then 3 to 15%. And then if you take it the next step, you'll see only a modest increase in mental illness, and I'll talk about that in a second. You'll see a more or less modest increase in substance use disorder, and then you'll see a group that receives both. It moves up incrementally. So here's the problem, in my view, with this data. If you look at national data where you're assessing people for substance use disorder and mental illness coming into jails, you'll see these numbers are much higher. And so what this tells me is that people with these conditions who are OHP members, because remember that's the database that we're drawing from, they're still not receiving services, because we would find that this number, instead of 45%, is likely in the neighborhood of 60 to 75% for people booked into jails in terms of having some level of substance use disorder. So we think there's a challenge in just people aren't getting services. And what we know here in Oregon, and the numbers are similar nationally, that only about 10 to 12% of people with a substance use disorder receive services in the prior year. And this is where the disease of denial comes in. People have these disorders and they are not seeking services for them. So partly it's access. We know we don't have enough treatment here in Oregon for substance use disorders, and partly it's people, individuals reluctant to seeking those services, so it's sort of a mix of all that pulled together. The other thing that these data don't tell us is the severity, right? So even though there's a modest increase in mental illness from 27% to 29% from these data, it may be that these with a 29% have much more severe conditions, because this is receiving any mental health services as coded. It doesn't talk about the extent or the severity of those conditions. So I just want to add some caveats to the data that we're looking at.
Does it also qualify personality disorders as DSM diagnosis in that, do you know?
That's a great question. I don't believe that we included personality disorders as part of that cluster.
And then one more question.
Yes.
Are the people with co-occurring disorders separate and distinct from the other two categories, or are they included? So is in the first column, is the 17%, 3% of that could be both mental illness and substance abuse?
You are testing my memory. This was over a year ago.
I'm just wondering if these are separate and distinct groups of people, or if they're...
Yes. No, excellent question. And I just don't remember the answer to that.
And I just wanted to reinforce from the CCO perspective, just what you were saying, that we don't have adequate diagnoses, so we have to use separate flags in our data to even know who we think might have substance use disorders. So that 6% and 3% are really underreported for what we expect of the population before they're even in jail.
Thank you. So same combined set of data here, again, using Medicaid data. So this has to do with emergency department utilization, which we've been hearing anecdotally was much higher for this population, people in and out of jails, in and out of emergency departments, and we wanted to be able to test that out and see what we got. So if, again, same process here. If you take all the adults on the Oregon Health Plan in 2017, 24% of that 500,000 people had at least one ED visit. And then this is a metric, this bottom number of 26 gives us a ratio. So if you essentially, the denominator is the 500,000, and then you look at the ratio of ED visits per member, and using 1,000 member months to create a number, you get the number of 26. So we'll track that. So first of all, anybody who's had at least one ED visit jumps from 24 to 49, so it essentially doubles, and then jumps up again to 60% for people with those frequent criminal justice. And in terms of the total visits, 26 per 1,000 member months here for the Oregon plan jumps up to 59 and then jumps up further to 84. So you'll see a very significant difference as for the frequent criminal justice population as we look at that.
Are those visits while they're in jail or not?
No. It was any visit in year 2017 to an emergency department.
But it could have been brought in by a patrol officer or whatnot, clearance
Right.
for confinement, or by the...
But billed to OHP, so once in the jail, probably wasn't billed.
Okay.
That's right. Yeah, if you think about what triggers this is a code that says that it's being billed out of an emergency department. That's the flag that triggers it. So a little bit shift in the data. So kind of looking at, so we have these roughly 100,000 jail bookings. That represents 60,000 unique people. But if we take out people who aren't adults, so these are juveniles who are in the system, it ends up with about 50,000 people. So roughly 100,000 bookings, roughly 50,000 people, unique adults in the system. So now we look at, here are the 3 or fewer, here are the 4 or more, and we look at all of those bookings, and here we're driving towards what's the likelihood that these individuals would have had a stay in the Oregon State Hospital at some point for the years 2013 through 2017. So we looked at that span of data because, frankly, it doesn't happen that often for people. And then we created a ratio. And on a ratio level for all of these, say 43,000 adults, it was about 10 stays per 1,000 in the non-frequent criminal justice. Just as to create that ratio. And the stay could be for any reason. It could be aid and assist, it could be civil commit, it could be guilty except for insanity. So any reason to be in the hospital was captured here. Then we look at the frequent, and getting to the bottom line here, it's over 3 times. So it went from 10 to 33, so much more likely. Still a relatively rare event if we just look at people involved in the, even in the 4 more categories, but much more likely to occur.
So these people that are unable to aid and assist or guilty except for insanity?
Or civil commit.
So we're talking 1% and 3%?
Mm-hmm. They're relatively small numbers, yep, in the grand scheme of things, yep. So same set of data, the 100,000 jail bookings. In this case, we were interested in knowing how many of these individuals have felonies and how many of these are person-related felonies. So speaks to the idea, the concept of dangerousness. Remember, we're separating that from risk of recidivism. So on the non-frequent criminal justice, we end up with about a 4% having a felony as the most serious underlying offense, and about 2% of the frequent criminal justice bookings. And most of the felonies, they're saying overwhelmingly property and drug-related offenses. So this gets to our risk categories. So again, the 100,000 bookings, these are the non. And what you'll see here is 32% of these were high risk in this category, 33 of the non, and double that roughly for the frequent criminal justice. And you might kind of go, well, duh, right? These are people who have many more jail bookings than the other group. Of course, they're going to be high recidivism. But keep in mind how this is being measured, right? It's being measured by the instruments that predict recidivism, and it captures a number of different elements, one of which is an important driver in these is criminal justice involvement, right? So it's natural that this would be higher than that, right? It's how we divide it up. But look what else is in that. So alcohol and drug use, employment, criminal thinking, criminal associates, how people use their leisure time. All of these are also baked into the cake, if you will. And the good news is that offers an opportunity for intervening differently. But what we also know from the criminal justice literature is if you take someone at at this level of risk for recidivism, and you only give them mental health or even substance use disorder treatment, it's not enough. It's necessary but not sufficient. And keep in mind, for folks familiar with this, mental illness is not a risk factor, but it is a responsivity factor. And what I mean by that is, if you are experiencing the symptoms of a mental illness, say, be it depression, anxiety, schizophrenia, thought disorder, those symptoms are going to interfere with your ability to learn and benefit from experience. They just get in the way of being able to do that. So that's why it's a responsivity factor. Substance use disorder is known as a risk factor, but it's also a responsivity factor. So if you're high, it prevents you from benefiting from experience, but it also, from the literature, we know that when you are using substances, you're more likely to become re-involved in the criminal justice system. So both of those things are circulating, and I think one of the challenges that we see is sometimes people think, well, if these individuals, because we know they have much higher substance use disorder and mental health needs, if we only give them those two things that they need, then it's all going to be better. And for this side, that's probably true, right? If they just get the mental health treatment and substance use treatment that they need, maybe some housing supports, it's not the other pieces that are driving the behavior, the antisocial thinking, who they hang out with, what they do with their leisure time, also the drug and alcohol, the employment, the family conflict, the work problems. All of those stack up on this side and may or may not be much of a factor on the other side. On this side of the fence, if you're really going to bend the curve on your high utilizers, then you also have to engage. The good news is that this population is also very often engaged with community corrections, and their job, what they're trained for, is not the old school trail and nail and jail, it's engagement and involvement in the kind of programming that helps with the dynamic risk factors that are also present on this side. So very important to do both. Mental health, substance use disorder, necessary, not sufficient. Using the other tools that we know what works from the criminal justice literature are critically important.
And one point I want to make that I think is correct, you can correct me if I'm wrong, is we have such a small number of people that up front are receiving services for mental health and OHP, and we just got told that it's probably underrepresented because of how they have to code it. That those aren't people that are seeking mental health and A&D treatment. They're not getting it until they get arrested and put in jail.
Right.
And then they get engaged.
Yes.
And it doesn't stop them from having committed the crime they committed, it stops them from recidivating.
Yes.
Okay.
Yep. Well said. So this next slide is a little confusing, and this is about homelessness, and I'll kind of give a little bit of context for it. So we really wanted to know what the homelessness rates were for this, and by the way, as we look at the aid and assist population we're talking today, here in Jackson County, the percentage of people who were homeless at the time of the booking that brought them into jail is in the range of 75%. So 3/4 of individuals, coming into the state hospital who are referrals from the aid and assist process here are people who were homeless at the time that they were booked into the jail for this offense. So it's huge. There's a correlation to that, and we could spend lots of time. That's no accident, and that's statewide as well. Those numbers don't vary a lot from Jackson County, although you're probably on the higher end of the spectrum. We also wanted to know, though, what the relationship of homelessness, because we've been hearing anecdotally that homelessness was a big part of the challenge in terms of this frequent criminal justice population as well. And of course, there's overlap between aid and assist and this frequent criminal justice. All right, so we wanted to know what that was, and what we found is that in the way that the jails capture that information vary enough that unlike the other information that we were able to combine and integrate together, we didn't feel that it could be integrated appropriately, and so we separated it out, which is why you see these different lines. We also couldn't get homeless data because not all jails capture it or capture it consistently from all the jails. So these were the jails that were available to provide that information. And so what I'll do is just separate this out. Is if we look at this non-frequent criminal justice, so those booked in 3 or more, we see numbers like 9, 28, 777. Now if we jump over, so Clackamas County, now we jump over to those who are frequent, 4 or more, we see a huge increase, more than double. So it goes from 9 to 21. That's a comparison within Clackamas Jail. So 20 to 42%, again a doubling. Morrow County 8 to 13%, a modest increase. Norcor 7 to 31%, huge increase. Umatilla 7 to 23%, and Washington County 16 to 33%. So you see routinely a doubling of homelessness, even if you look at the non-frequent criminal justice or the frequent criminal justice and that. So clearly it plays a role in this population and needs to be addressed. And of course, it's a very difficult thing to address.
Can I say one thing, Steve?
Yep.
As far, I can only speak for the Jackson County statistics, but everything that we have on homelessness is self-reported at the time of lodging and includes people who just don't want to give us an address, right? And so I actually think that in our county, those numbers are probably inflated a little bit. They're probably not quite that high, but it's just the only way we have to track it. So.
Okay, thank you, that's helpful.
The other piece too is when you're looking at frequently involved individuals, they tend to be a little more savvy with the criminal justice system. And we have a huge number that are booked and rebooked, and they don't want to be found typically. So I think that would also contribute to this higher number. So I really don't think that that's truly representative of our population. I mean, I'm sure we have a lot, but that's pretty
If
high.
they can get out on house arrest, they have an address real quickly.
Right.
I don't know if you know this or not, but Umatilla and Morrow County are the same jail.
Okay,
So you separate out their data, but Morrow County doesn't have a jail. They contract with Umatilla County.
gotcha. Okay. All right, so at bottom, I think the challenge that CSG was trying to help Oregon solve at the time is better understanding the people who are in and out of Oregon jails and some of the ratios that I think of often that interestingly seem to relate just as well to healthcare as they do to the criminal justice system. Is you have the 80-20 rule and the 550 rule, and in healthcare, and it maps out pretty nicely in the criminal justice world, about 20% of individuals account for about 80% of the resources. And the 550 is that about 5% of individuals actually account for up to 50% of the resources in the system. So the whole idea of looking at a high utilizer population is to see a couple of things. And one is, if you think about it maybe a little differently, is that what's going on with that 5%, that the resources that we're investing in that population, because it's huge, like why is that not working very well? What is it about the approach and the resource allocation that we currently have for those individuals that isn't bending the curve on their utilization of public safety and or healthcare resources? What could we be doing differently? So I think that's a really interesting exercise, and data can help inform it. And then as you look at those populations, and especially if you look into that 5%, oftentimes what you see is that the system as a whole ends up being pretty reactive. We respond to things, right? There's a problem, we develop a solution. There's often an opportunity, once you've identified a 5% or a 3% or a 1% or a 10% population, that once that population is known, you have the opportunity to say, all right, we know this population is a high utilizer. We know that what we're currently offering doesn't seem to be working so well. Let's get ahead of this, figure out what we can be doing differently in a proactive way, in a multi-systemic way that helps bend the curve on their utilization. And that, if we do that well, will improve public safety, reduce healthcare costs, and allow resources to be freed up for other individuals in the system as well. So that's the concept behind it, and I think that's the hope for the Impacts program. As the grants go out, as we look for innovative ways to address a high utilizer population of both criminal justice and healthcare resources differently, and be happy to answer questions about that. I assume that Stacy's been keeping you up to date on where the committee is at in terms of developing the RFP, et cetera, but happy to answer other questions or just questions from as the behavioral health director role.
So we have this discussion in our community about we don't need a new jail because we just need more mental health services and A&D services. And I asked you specifically about the civil commitments and aid and assist and guilty except for insanity being 1 and 3% of the bookings, because there's this kind of mantra that that's what all these people in our jail are mentally ill or substance abusers, and that's the reason why they're there. So if we deal with that, they won't end up in jail. And I guess you cross-referenced, if I remember correctly, there were about 80% of people that were in the criminal justice system that were enrolled in OHP. And
Two-thirds.
Two-thirds.
Yeah,
Okay.
80% had been on community supervision at
Yeah,
one time or another.
yeah, community supervision is what I'm
Yeah.
talking about. Because that is the place where we have more tools
Yes.
to deal with people who are already justice engaged. So the argument in our community is, what about the people that aren't justice engaged yet? Those are all the people that are enrolled in OHP that aren't getting those services. And the people want the county to do something about it, but the county doesn't provide those services. We do provide services if they're criminal justice system engaged through justice reinvestment and also through Community Corrections Act funding and also juvenile crime prevention funding. Once again, not the county's responsibility. We contract with the state to provide those services on behalf of the state. So I guess my question is, from the data that you have, it looks to me like where the county can intervene for people that are already engaged in the system, so people that are in the community corrections system, versus people that aren't in our system, which is what our community is arguing. We need to divert those people from even getting into the system. What kind of proposals are you looking at that are meant to divert that? I know the CCO applications to the Oregon Health Authority require them to talk about how they'll divert people from jail, emergency rooms, and psychiatric centers. But what kind of, in this particular project that you're working on, how can that help us divert people who aren't, coming into the system? Because all the data you showed today that really the county can impact are people that are in the system, the 1% and the 3% of people that are, going to the state hospital essentially.
So there was a lot there, and I'm not sure if I've flagged what your primary concern.
Primary concern is, how do we get to people, and how does what you're proposing get to people before they having to be taken to jail? And really, what kind of impact can we have when we're talking the people that do get to jail? 1 to 3% are being, committed to the state hospital. We're not talking about diverting large amount of people, even when they do get to jail.
Well, if you don't mind, let me reframe that a little bit.
Okay.
So obviously, working for the state, we're very concerned about the utilization of the state hospital because we're bursting at the seams. The aid and assist volume hasn't gone down. The guilty except for insanity population has gone up for the first time in like a decade. And let me explain why that's so important, and I'll get back to this, is that the average length of stay for someone coming to the state hospital under aid and assist is about 80 days. It's about 120 days for a civil commit. It's 2.5 years for guilty except for insanity. And capacity is not just beds for anybody who runs programs. It's beds plus length of stay. So if your length of stay is 10 days, you get one thing. If it's 100 days, it's like a tenth of what you started for. So that 2.5 years, and now we have a whole nother unit at the hospital, more than we did a year ago, with these individuals. It prevents us, it's like 11, we could admit 11 aid and assist patients for each GEI. So it has a huge long-term impact on hospital utilization. So we are very concerned about that because it goes downstream to the ability to accept people from the community on aid and assist, GEI, and our civil commits are now up to 50 on the waiting list. But we're very concerned about the state hospital. But I would actually turn this back because the impacts program and these data are all about how to think about managing the resources that you have and maybe requesting new resources to manage things differently at the local level, knowing that there is a connection with state hospital utilization, but the goal of this project was never highly focused on impacting the state hospital. And as we looked at the data, there is a relationship here. But it's the rare case that does make it to the state hospital and targeting the types of resources that you need for that population, need to be focused a little bit differently. But I think the real benefit of this is to look at this whole population differently. And I'll just say from an OHA perspective, from my role, what I want to do is retool how we support communities in doing this work. And here's what I have in mind. I think we've sort of been chasing our tail with the aid and assist. We are not catching up with this population. It is growing, and not just here in Oregon, but nationally. It's growing for reasons we don't yet fully understand. I believe drug abuse, especially methamphetamines, is playing a role. I think we've treated it too much like a mental health problem, and yet I think it's more complicated than that. I think it's a co-occurring challenge that we have. It's partly about resources. But I think we need to think about this rather than an aid and assist problem as a how do we provide intensive community services across a range of populations that need them? And then how do and my boss restructure our unit to better support communities in doing that? Right now, we have essentially one person at OHA who helps communities with the aid and assist. That's ridiculous. Like, we can barely monitor what's going on in your areas. We can't provide the kind of support I think that would be helpful. You also don't have the money, right? So there's, I think, 6 counties that received extra funding over the last 2 biennia for the aid and assist. These were high utilizers, people who signed a lot of folks. You get like $70,000, $80,000. Like, you can't even hire a staff for that to do that work for aid and assist. It's ridiculous, right? You can't do the work with that level of funding. So another thing that we've asked for is to double the amount of funding that we have at OHA to better support communities. And then what I would like to do, sort of going back, is to restructure our staff. So instead of just looking at aid and assist as it slides to the pie, look at civil commits, GEI, aid and assist, all as a cluster of people who have very complex conditions, who are court involved, who need a special set of wraparound services to really support them truly in their community. And in doing that, we'd really like communities like Jackson County to build on the work that you've already started, is to see if you can slow down the trajectory of referrals through investing the money, having more money to invest, and investing that money differently, more proactively. But the other piece that I think people forget is this is not a hospital solution. People who go up to the hospital and aid and assist are there on average 80 days. They are coming back. And they're coming back stabilized, but really nothing more than that. And that stabilization can quickly evaporate. It can evaporate in 24 hours, as you probably well know, whether that's in the jail or back in the community. And so how do you establish the kind of supports and services targeted proactively for this population to sustain the gains? Once we do get them stabilized, whether it's at a local emergency department or a state hospital, so that roughly $160,000 that we just spent to stabilize that person prior to moving them back to the community doesn't go up in smoke, that person actually can sustain that level of stability by having the right resources, mental health, substance use disorder, social services, housing, all of those pieces of the puzzle that we know this population needs. Otherwise, that resource does not actually help in the long run. The hospital was never a solution for this population, will never be a solution. It has a role, a really important role, but it's a limited role. And we need to, I think, retool that so that we have a much more community-based restoration plan here in Oregon and less dependent on the hospital. Again, hospital has a role, but it needs to, the true win here, the way to change the trajectory for yourselves and for the state hospital is in the community-based services. Sorry,
and when you say for yourselves, it is the state that funds those things.
Yeah.
Okay, I just want to make sure our crowd understands that here.
Yeah. We have a role, and I think, frankly, the CCOs have a role. As we saw, at least 2/3 of these individuals with frequent criminal justice are OHP members. We suspect that number would be higher if all the eligible individuals were enrolled. And now we have intensive case coordination. We have more tools and and an emphasis on this population that we haven't had before under SUP 2.0. We think that ends up making a strong partnership with the existing resources that you have. So we're looking for opportunities to leverage that partnership.
Do you think the resources that you're allocating out, either through CCOs or through additional grant programs, are actually making it to services on the streets? Or
it's a really good question. I wish that we were staffed to be able to better understand that. What we know is, at least on the aid and assist side of the fence, is that nobody ever looked at what the costs were. We never did that. We never had enough money to support communities in doing this work. And that work has ramped up substantially. It's more than doubled over the last 5 years, and we haven't kept up with that. And so for the first time this fall, actually, we took a look at, well, what are communities doing? What does it actually cost to do this work? And what we found, even with those counties that we had provided more robust funding, it wasn't enough to meet the needs. And so that's why we've asked for that doubling of the funding for aid and assist. But again, in my view, that's using that as a sole focus for aid and assist will never catch up to it because it's after the fact. We want to get people before they're arrested, before they're booked into jail, before this whole process starts. That's where I think the real opportunity lies.
When you say you've asked for a doubling of the funding for the aid and assist population, how is that proportionally split between centralized funding at your level and community-based funding out at our level?
So currently in our budget, Service Element 4 has roughly $7.6 million that we distribute unevenly across the state. We've asked for another 4.2, but you got to double that number because by the time it reaches us, it'll only be for half of the biennium, so it's only for 1 year. So we're asking for it for ongoing funding. That'll essentially double that amount of funding, and that's money that we push out the door to counties. What we're also in the middle of is rethinking our county financial assistance agreements. Those are the contracts that we have with counties to provide those services for which we provide general funds, not the Medicaid funding. And we're in the middle of trying to rethink that so that it's in a way that provides counties more flexibility, but frankly more accountability in the process. And I like the idea of bundling a variety of these service elements all together as part of this intensive communities services approach. So aid and assist would be a part of that. Mobile crisis, ACT teams, choice contracts, jail diversion, all of those I think come together nicely as a whole and sort of take away some of the requirements and restrictions on that, and then offer that maybe as a pot of money that the community uses for that. Again, to offer more flexibility to meet community challenges, more accountability. How do we know that people's lives are being improved, that there's fewer arrests, there's fewer jail bookings, there's fewer emergency department, and most importantly, that people's lives are improved through this array of funding, and then working in concert with the CCOs, because there clearly needs to be a way to braid funding and integrate those approaches across those, because otherwise we just have more elements of a fragmented system. We need to collaborate. These are multi-system involved individuals. Other questions? Good questions.
Well, on that community restoration, isn't a big deal is housing?
Yes.
And I didn't hear you say anything about that.
Yeah, great question. So housing needs to be in the mix. And you may have seen the speaker's very interested in looking at homelessness, houselessness. The governor's already invested a significant, not focused on the homeless population, but in bolstering housing as a whole in Oregon. I think there's opportunities through the impacts program of looking at that. Keep in mind, part of it is access to funding, but so much of housing, and I'm sorry I didn't bring it up, other than it's a constant theme in this, is that local dynamics play a huge role. The developers, not in my backyard, all of the elements that it takes to stand that up, a lot of that is local. And so some of what we can do as the state is provide the resources, technical assistance, et cetera, to help you stand up services. But frankly, some of this housing stuff needs to fall on the community shoulders. So happy to support to the extent that we can, but I think it needs to be a shared responsibility. No one agency can do this work. We can't solve this from OHA's perspective. It needs to be a partnership, and I think that's what we're really trying to drive towards, is this partnership. It's not us versus them.
I would also say, excuse me, I'm sorry, I didn't mean to step on you. Sometimes it's sending people to the home they do have is an issue, because they still won't follow through.
Mm-hmm. Yep, that's accurate.
You've pretty much, in making the finding that housing is a social determinant of health, lessen the restrictions for CCOs to be able to help with housing. Yes. And then there is kind of a community movement here, I think, through the CAC, with increases in special project funding and increase in vouchers through the Jackson County Housing Authority. So I think those things are starting to happen more intensely here. I don't know that this particular program, the only thing I would say is maybe remove some of the strings that come with all the money, like you were talking about, kind of pooling the funds, because then local communities can determine how to prioritize those things. Mm-hmm.
Yeah, very open to that. And the impacts program, that RFP will be coming out shortly. You'll kind of see what that looks like. But the hope is that communities who submit applications will come up with creative solutions that are locally driven. What are the tools in the toolbox that you don't have otherwise? What money do you need? What resources do you need, whether it's housing, support, services that you don't already have in your toolbox, or to grow things that you couldn't grow otherwise? What does that look like for you, and how would that drive towards improved outcomes for these individuals? Good. Other questions? Well, thank you so much for your time and your interest.
And just to make a note of the fact that Steve has spent all morning working with local community partners on finding solutions and identifying different pieces that might work. And so now he finally gets lunch, and much deserved. But again, this is at least the second time you've been down to Jackson County since I've known you've been working with the state. And the fact that you're willing to come into our community and have these conversations means a lot. So thank you again, Steve. We have talked a lot about some of the different challenges that our communities faced, and one of the hallmarks of this group in particular is that there's a number of people willing to innovate and create programs that directly address them. They utilize partnerships, they utilize bold approaches towards this, and I think we've had Judge Greif come and talk about mental health court before, but we're very fortunate enough that she's going to talk about the aid and assist docket and some of the other strategies that go along with that. So Judge Greif, thank you.
Thanks. Okay, aid and assist is governed by a statutory scheme in Oregon. Basically what it is if there is a defendant who's charged with a criminal offense, could also be a probation violation or a punitive contempt, something that could land them in prison or jail, and they have a qualifying mental disorder. And when I say qualifying mental disorder, we're looking at schizophrenia, schizoaffective disorders, bipolar, major depression. There's a list of them that qualify. And as a result of their mental disorder, they're either not able to understand the nature of the proceedings, they cannot aid and assist and cooperate with their defense counsel, or they cannot participate in their own defense. And you may also hear the term fitness to proceed, a defendant's not fit to proceed, or incompetency, but I probably will largely refer to it as unable to aid and assist or aid and assist, just for that's what the term I tend to refer to. So as I mentioned, there's a court process that occurs to determine if someone is unable to aid and assist, and that's either done by a certified evaluator or by a court hearing. And if someone is found unable to aid and assist, then there are possible outcomes, 3. 1, they could go up to the state hospital for restorative services. 2, they could remain in the community for local restoration services. Or 3, if they're unable to aid and assist, but they don't meet the hospital level stay criteria, and we don't have the resources available or appropriate resources to deal with them in the community, and they're in custody, they get to stay in jail and have a review hearing every 7 days. Obviously, that is not the ideal situation for us. If someone is sent up to the state hospital, they're not there just forever. There is timelines. They can only be held up there to the time equivalent to the possible maximum penalty for the most serious of their charges, or for 3 years if the charge could potentially carry more than a 3-year sentence. And any defendant who's been in jail and at the state hospital, all of that time counts towards their maximum sentence that they have served. So in July of last year, Governor Brown signed new legislation that was known as Senate Bill 24. And what that basically did was it added some components to the aid and assist process. And what it required was that all aid and assist defendants now have to be evaluated by the Community Mental Health Program, which in our county is Jackson County Mental Health. And they have to determine, are there services and supervision necessary to safely allow the defendant to gain fitness? Are those available in the community? So now, in order to send someone up to the state hospital, it's a little bit stricter criteria. And this directly came from all of the increased numbers in aid and assist that we're seeing. And in fact, there is a Ninth Circuit case, the Mink case, as it's commonly called, where that basically said these defendants need to be, if in order to aid and assist, if they're found unfit, they need to be sent to the and they're in custody, they need to be sent to the hospital within 7 days of the signing of that order. So the state hospital was scrambling because the aid and assist population has gone through the roof. They don't have enough beds up there. So they reached out to their buddies in the legislature and said, hey, what can we do to help comply with this court mandate, not find ourselves in federal contempt, which was a threat. They were found in contempt by a state court in Washington County. And so here we go with this new legislation. So now the law is that in addition to the finding about unfitness, that in order to go to the state hospital, the defendant has to be either a danger to themselves or others, the dangerousness prong, as we call it, as a result of a qualifying mental disorder, that a hospital level of care is required due to the defendant's dangerousness, and the acuity of the symptoms of the defendant's qualifying mental disorder, and that services and supervision necessary to allow the defendant to gain fitness are not available in the community. So what that has done is essentially really put some stringent restrictions on who we can send to the state hospital. Unfortunately, in Jackson County, like many other communities around the state, we don't have a lot of local restoration services resources. So when we have someone that is unable to aid and assist, but they don't meet the dangerousness statute requirement, oftentimes they end up sitting in the jail, and we have to do those 7-day review hearings because we don't have any other options. There is some proposed new legislation, Senate Bill 1575, which will be part of this upcoming regular session that starts, in like a week or two, I believe, that is going to getting rid of that dangerousness prong, because that has been a real hurdle for us. For felonies, a hospital level of stay would be required due to public safety concerns or acuity of symptoms of a defendant's mental disorder, and that appropriate community restoration services are not provided. For misdemeanors, it requires either a recommendation from a certified evaluator that the defendant requires a hospital level of care and a statement from the community mental health program regarding available community restoration services, or it puts it on the court to make findings concerning the severity of the defendant's symptoms, present public safety concerns, and whether appropriate community services are provided. So it allows a little more flexibility than just with the dangerousness. We're really looking at public safety concerns and the acuity of symptoms. It would also modify the procedures if that legislation is passed to when circumstances authorizing the commitment of the defendant up to the state hospital no longer exist. So just a few statistics from Jackson County. So if you go back to April 2018, we had 5 people at the state hospital on aid and assist. If you go to October of 2019, I think we had about 35. The numbers have gone up substantially. And we're averaging about 5 new admissions per month from Jackson County. I think the state hospital today, they said they have about 280 people up there on aid and assist. They're expecting that to hit around 300 within the next few months. And that's way over their allocation for the number of aid and assist beds. One good thing that we've done in Jackson County is we're really mindful of felonies versus misdemeanors. We really are ultimately trying to just get people to the state hospital who have felonies, if we can, because we'd like to be able to treat those with just misdemeanors in the community. We're currently, we're at 19 at the state hospital, so we're bringing the numbers down, which I think is great. And 94.7%, we just have one person up there on a misdemeanor. Everyone else is there on a felony. So I think that is a really good, and we've been consistently in high numbers. So we are doing a really good job of flushing those cases out. If you look at, just to give you an idea of the cost, so I think it's $1,324 a day to house someone up at the state hospital. So if you take the average stay of 80 days, that's over $105,000. And if you think about how many people we have up at the state hospital, just think about our county alone and how much that is costing in funds. So, because we determined that this population was continuing to grow, that we were seeing the numbers exponentially go up, I think we're also noticing an acuity of symptoms. We made a decision about a year ago to start having conversations about implementing an aid and assist docket. And Multnomah County started one in 2016. There's a few other counties around the state that have gone that direction as well, and more are heading in that direction because they're realizing that that is really what is needed to manage this population. And we reached out to Multnomah County. I reached out to Multnomah County, to Judge Waller, and got a lot of information from her, kind of a roadmap. How are we going to set this up? What are we going to put into place? What do we need to put into place? What court processes and procedures? Who needs to be a part of this discussion? Who needs to be on the team? And we ultimately ended up starting that docket in July of last year, right around the time that the new legislation was signed. Initially, when we started it, we thought, let's do it every other week. That'll cover it. Unfortunately, with the number of people we have in this population, it was quickly determined every other week wasn't going to cut it. We had to do it every week. So I do it along with Judge Laura Cromwell. She's our other aid and assist judge. And we do it every Tuesday at 4 o'clock. And anyone's welcome to come, by the way, and watch aid and assist. It's in Judge Cromwell's courtroom today, courtroom 203, 4 o'clock. So we also have a designated queue to review all the documents, all the reports from the state hospital, all the independent forensic evaluations, all the motions and orders that get filed. We have a chance to review all those, just the two of us. And that is streamlined it down to just have the two judges be in charge of all the documents. We make sure that they get out in a timely manner. Julie Travers, our court supervisor, has streamlined the court process, and she has staff specifically trained to help with this population and with these processes and procedures. And we have a designated aid and assist team, and it's some of the same people that are on the mental health court team. It's we have a representative from the jail, from the sheriff's department. We have a representative from options. We have a representative from Jackson County Mental Health. We have the two judges. We have a designated probation officer. We have a designated defense attorney, and we have a designated prosecutor. So those folks are all available to talk about these cases. And I can tell you, there's a lot of ongoing communication. There's a lot of emails that go back and forth. There's a lot of meetings and discussions about this population and the people that are on our docket. And hey, what can we do to help this person? Does anyone have ideas? How do we transport this person here? How do we get this person into a foster home? So it's continuing, ongoing discussions between this team of folks to try and get the best outcomes we can for these people. We have a staffing session that's available every other week for misdemeanors and low-level felonies. So in the event that maybe we don't want to go the formal aid and assist process, we can come up with some other options. Maybe we can do a civil commitment, a guardianship. Maybe we can do some kind of deferred sentencing or diversion proceeding, a dismissal of charges, something that isn't going through the formal aid and assist process with either placement at the state hospital or placement in local restoration services. On the 4 o'clock docket, we do everything from the hearing to determine if someone is unfit. We do status checks and compliance checks on people that are out participating in community restoration services. We are typically the first hearing someone has when they come back from the state hospital as either being restored to competency or being found never able to aid and assist. And if someone is found never able to aid and assist, the court is mandated to dismiss the charges. So, and sometimes those are really serious charges. I just recently dismissed a Measure 11 sex offense case because the gentleman was determined never able to aid and assist in his own defense. And it's statutorily required that the court must do that. And luckily, we found a foster home for that guy where he's now placed through adult services. So he's going to have some kind of oversight with him. But sometimes there's cases where we don't have that in place, where there's nothing else we can do but dismiss the charges. There's nothing to motivate or force the person to do anything because the court mandate is no longer there. The charges are no longer there. There's no release conditions. So they may just be dismissed with back onto the streets with nothing in place. We try not to do that. We try and come up with a plan, and we have come up with many, but it doesn't mean the person's going to do that voluntarily. I mean, we had one guy that we did this plan to send him to the Beckett Center, and within a day, he walked out the door. So even the best laid plans don't always end up working. So that is, kind of the docket that we do, and it's to try and have the coordination of the judges and the team to have a more efficient and humane system, to reduce the time in custody, consistent processes and procedures. And I think, so far we've had some good results. It's frustrating when you don't have options for people because we don't have necessarily the local restoration options that we would like. That's frustrating, but we still managed to come up with, some good outcomes and some good solutions for a fair number of folks. Some of our challenges have included, just like I said, the sheer numbers of people who are not able to aid and assist. The numbers are skyrocketing. The lack of space at the state hospital. The limited space and dates for transport. So for in-custody defendants, typically the jail will take them up there on Thursdays to the state hospital. They do other days too when they need to comply with the court orders, but just to give you an idea of these are just the Thursday Salem transports. 2017 was 27 people, 2018 was 46 people, and 2019 was 63 different people they took up on Thursdays to the state hospital. As I mentioned, limited resources for local restoration services. We don't have secure residential treatment facility options here. We have a lack of housing options. We have an ongoing issue with not enough mental health providers. We have a high number of aid and assist defendants, probably somewhere between 60 and 90%, that have a co-occurring substance use disorder. And again, limited space for treatment, particularly if someone meets a residential level of care for alcohol and drug treatment. And so many of these people are homeless, they can barely meet their basic needs. And I mean, 60, 70% would be my guess, just as a rough number. So in addition to the aid and assist docket, we have been doing some other things to try and collaborate with this population. The Chief Justice of the Oregon Supreme Court, Martha Walters, is very concerned about this population and behavioral health in Oregon. She formed a behavioral health advisory committee. It's also part of the OJD strategic plan. And Tina Qualls is on that, our trial court administrator. I'm on that, and Judge Cromwell's on that. And I also head up the mental health court subcommittee of that group. So the idea is, hey, let's collaborate together as the OJD and come up with best practices for docket and case management, decision making, for court users that have behavioral health issues. As mentioned, Stacy Brubaker is on the Impacts Grant Committee, and she is also on the Senate Bill 1575 committee, the committee to try and redo Senate Bill 24. Judge Cromwell also is on a statewide committee involving legislative changes to the PSRB GEI statutory scheme. So we have a lot of people from down here who are working collectively with folks around the state to try and implement some very much needed changes. And then just one other thing I wanted to mention was that I'm the mental health court judge. That program has been in effect since 2015. A lot of the people that were on aid and assist at some point, so they were found unable to aid and assist, many of whom went up to the state hospital. When they come back and are restored to competency, a lot of those people go into mental health court and have great success. Once they get stabilized, they get on their meds, they get some supportive services around them, we find them some housing, they have that ongoing interaction with the members of the team, their lives vastly improve. And so these folks can get better. And they will get better if they have the right services and supports and treatment in place. And then if they have that ongoing continuum of care, when they do reach a point where they're found able, if we can continue with those services, not just when they're part of the criminal justice system, but well beyond that, that's the goal. Keep them safe, keep them stable, keep them out from coming back into our system. And anything, that the courts can do to help that, we're all in. Anyone have any questions?
So I heard you mention while they're in the criminal justice system and after the criminal justice system.
Yeah.
What we're taking right now is a lot of incoming from people who want the county to do something about before they get to the criminal justice system. It sounds like for you to be able to do something, they have to come to your system.
That's the problem.
Yeah.
That is the problem. You just don't it's the same way when I was over doing juvenile with the child welfare folks. You just don't get many people to voluntarily do it. You have to have the teeth, whether it's treatment court, criminal court, child welfare in the juvenile court. I wish that it wasn't that way. I wish everyone would just, if they had a substance use disorder or a mental health disorder, they would say, I need help, help me do whatever I can. But they don't, and it's difficult to negotiate and navigate your way through barriers. So you also have that. And you have people not thinking they're mentally ill. That's a symptom. So there's so many different factors that play into that, and it is really unfortunate that, you do need the court mandate. The threat of jail, the threat of, going to the state hospital, the threat of losing your kids, whatever it might be, that you need that external motivation in addition to anything you may have internally. And I can tell you, most of the people in mental health court, they're there because they're not going to go to prison, or they're going to get their felonies, their charges dismissed, or they're going to get a felony reduced to a misdemeanor. Every once in a while, I get someone that comes in. I think we have one guy right now that he's like, I just really want to get help. I want to get better. I don't want to keep living this life. That's like a rare bird. Most of the time, it's, I don't want to go to prison. I don't want to go back to jail. I don't want to have a felony. So it's that external motivation.
And I just want to add to that too, because what we see is with certain allegations being decriminalized, we now no longer have the hammer to hold over people, which is the catalyst to helping them recover.
Do you think that the increase in commitments, you said 17 and 18, 19 going from like 29 to 68 or something, I think, also corresponds to our increase in criminal filings? Because we have the number 2 highest criminal filings in the state.
Absolutely.
So the fact that all of these criminal filings, a lot of which are people who get out of jail and don't show up for court, end up causing us to file more cases.
Absolutely.
Perpetuating people then needing to go to the state hospital coming into the system.
Absolutely. The fact of the matter is we have so many failures to appear. Come sit through morning arraignments any day, you'll see that 50 to 75% of the people don't show up. So then those people get a warrant, then they get arrested, and then they get new charges. It's often a drug charge, misdemeanor meth or something like that, and then they're out again, and then they do the same thing and the same thing and the same thing and the same thing. And we all know that using methamphetamine and other substances, if you have a mental illness, is going to just exacerbate your symptoms a million times over. So yeah, it's just it's a revolving door.
These people that you deal with are very intense to deal with. They take more resources probably than anything else the
Absolutely.
system takes. And 68 is a lot of people, but just to add some perspective, we booked nearly 14,000
Sure.
people into the jail. So
Yeah.
68 of 14,000 people in a year went, but they take a lot of resources.
Absolutely. And I mean, you think about the mental health court numbers, for example, we've capped it at 15, and that's for that very reason. And I've said, well, I'll go over if we get close, because we're kind of getting close to that right now, and there's a couple more people that I think would be good candidates. But that's exactly why, because they're so resource intensive. Even though I have this whole team of people that bust their butts every day to get these people's lives squared away, it's still not enough, because they're so messed up on their mental illness, their substance use, their physical health, whatever it might be.
They are the 5% that used to 50%.
Absolutely. Yeah,
Judge, one last thing.
sure.
How many times have you seen like somebody coming into the criminal justice system, maybe have a substance use disorder, but maybe not, they're not as presented as mentally ill as, and you see them progress through the system? I mean, does that happen quite a bit? Because I know of several cases where people have
Yeah,
first
I mean-
arrest, and then as you see them kind of like the faces of meth, but 2 years down the road now they're completely.
And I think what you see is you see them gradually move up in seriousness of offenses. It starts out as your disorderly conducts and your trespasses, and then you go to kind of the resisting arrest and the harassment, and then the next thing you know, someone's out stabbing someone in a sidewalk as they cross the street. I mean, it's just there's this gradual, it seems like also in addition to their acuity of their symptoms going up, seems like they tend to ratchet up with the severity of their crimes, which is really unfortunate. Any other questions? Okay.
Judge, thank you so much for your time today. So,
I was texting Doug Houston throughout this and asking him if he'd rather try and do a condensed version. We're going to actually postpone Doug's presentation. I think it's really important that we give it the full time it's due. And I also think it's really important that we do show what local supports and interventions are in place as we gave the state ample time. So are there any other roundtable announcements today? Well, with that said, I want to thank everybody for their time, and we'll see you next month.